Good afternoon, everybody, and welcome to the session on comparative risk assessment. My name is David Blazes of the Bill and Melinda Gates Foundation, and I'm really honored to be here to moderate this panel, which promises to have a really lively discussion. I actually think this is probably the most interesting of the sessions, if I do say so myself, mainly because the risk factors, it's really where the rubber meets the road. It's where we need to target our interventions. And at the Bill and Melinda Gates Foundation, we obviously like interventions. We like to impact disease. And so I think understanding risk factors is really, really important. And so I have a couple themes that I wrote down that came up as I prepared for this, and I modified them a little bit this morning listening to the discussions. But there were three themes that really struck me as important as we discuss risk factors. The first is the importance of data quality and access and data gaps that are out there, and really their impact on policy. And I think the IHME and the GBD in general does a great job of identifying those and really pushing the limits on data quality. And we'll certainly hear about that. I think precision is also really important. I think as we've seen with the evolution of the GBD, these estimates have become much more precise. And if you look at you can look at this in many different areas. So certainly the timeliness is really important. We heard already this morning about the annual updates of this, and that's one way to get more precise, is to be more timely. I think the locality and getting to a very local level where decisions can be made is also really important. And again, more precise. I think the GBD is more precise in that fashion. And then more pertinent to to our topic today, the risk outcome pairs, I think, is also much more precise now. And you saw that only a handful of risk factors were studied in the initial GBD, and now we're up to over 80 risk factors and their associated pairs with outcomes. So again, more precise. And then the final theme, I think, is controversy. And I'll echo Richard Horton's theme this morning. Controversy is not bad. It's actually really good in scientific endeavors. And so while I won't shout it, as Richard did, I think controversy is good. Risk factors happen to be among the most controversial out there, I think, and many of you understand scientifically the debates around salt or high blood pressure, even ambient pollution. And so these are not topics that are not without controversy. And so this session will actually capture some of that controversy, and we should have a lively discussion. So we have a very esteemed panel today. You can see their complete bios in the program. I'll just do brief introductions now. So our speaker is Assistant Professor Ashkan from IHME. He's both a physician and nutritional epidemiology expert, and then was the primary author of the risk factor paper that was published in The Lancet a couple weeks ago. Our panelists will then give short responses to this presentation, and they include Professor Salim Yusuf, the Executive Director of the Population Health Research Center at McMaster University. He's one of the foremost experts in cardiovascular disease, especially as it pertains to risk factors. He's published over 800 articles in the scientific literature, so a very esteemed member of academe. Professor Michael Brauer from the University of British Columbia, right up Route 5, directs the BRIDGE program there, which links public health, engineering, and policy, and he's an expert in environmental respiratory disease, especially due to air pollution, obviously a big concern in many parts of the world. Marissa Reitsma is a researcher from IHME, who is focused on estimating the burden of disease related to tobacco and high body mass index. Again, probably some of the most important risk factors out there. And then finally, Dr. Claudia Stein is the director of the Division of Information, Evidence, Research, and Innovation at the WHO Euro Office. She's had extensive experience in the field in India, China, and Europe. And has worked at WHO headquarters as well. And she'll touch on the policy implications of risk factors. So we'll finish with some time for questions and look forward to great audience participation there. So with that, I'll turn it over to Professor Ashkan.
Good afternoon, everyone. Thank you, David, for the introduction. It's a great pleasure to be here. I would like to start by acknowledging the contribution of more than 1,000 collaborators who have contributed to the risk factors section of GBD. And I'd like to take this opportunity to sincerely thank all of them for their valuable contribution to this work. Over the next 20 minutes, I'm going to provide you with an overview of the comparative risk assessment analysis in GBD 2016 and briefly discuss the key findings of our risk factor analysis and also briefly discuss some of the methodological improvement that we have been able to implement in this round of GBD and some of the methodological improvement that we are aiming to implement in future cycles of GBD. One of the most common questions that we are always asked in GBD is that how risk factors are selected, why some of risk factors are missing, or more specifically, what criteria are you using to evaluate the strength of epidemiologic evidence for each of risk outcome pairs that are included in GBD. As with previous rounds of GBD, in this round we also used the evidence grading criteria from World Cancer Research Fund, or WCRF. And we only included the risk outcome pairs for which the level of evidence is convincing or probable. In GBD 2016, we evaluated evidence from more than 2,300 articles to establish causality for 481 risk outcome pairs. In this evaluation, we primarily focused on the evidence from prospective studies. Randomized control trials were available, and also prospective cohort studies. And for 34 risk outcome pairs for which evidence from prospective studies were limited, we also included evidence from retrospective study, mostly case control studies. After selection of the risk outcome pairs, the next step is estimating the attributable burden. To do that, this burden estimation basically starts with 3 types of input data: exposure level by age, sex, country, and a year, effect size of the exposure on disease incidence or mortality, and optimal level. For example, if we are interested in estimating the burden of ischemic heart disease or IHD due to high BMI, we need to know what is the mean and the standard deviation and the shape of a BMI distribution by age, sex, location, and year. We also need to know the relative risk of ischemic heart disease incidence and mortality per unit increase in BMI, and we also need to know what is the optimal level of BMI. Using these 3 input data, we estimate the population attributable fraction, which represent the proportion of the disease burden that could have been averted if the BMI level had been sustained at the optimal level. And by multiplying population attributable fraction to disease-specific burden, we estimate the basically attributable burden for each risk outcome pair. In each cycle of GBD, in addition to adding more data sources to this input analysis, we also making improvements in our estimation process. This slide summarizes some of the key methodological improvements that we have made in this cycle of GBD. For example, new methods was developed to adjust for tourism and unrecorded consumption of alcohol. For dietary risk, we recreated the GBD diet database and standardized the definition of the dietary risk factor across different sources. Also, we take into account the within-person variation, and this year estimate the basically usual intake rather than basically daily intake. Also, new methods were developed for estimating a second-hand smoke and physical inactivity. Additionally, this year we use ensemble technique to combine commonly used type of basically probability density functions to create a new distribution that better fit the individual level data for each risk factors. Now let's take a look at some of the key findings of the GBD 2016. This slide shows the ranking of the leading risk factor for DALYs at the global level in 2016 for men and women. As you see, the top 10 leading risk factors for DALYs are comparable or are relatively similar among men and women. but their ranking are different. Smoking, high systolic blood pressure, and low birth weight were the leading risk factor for dialysis among male, and metabolic risk factor, high systolic blood pressure, high body mass index, and high fasting plasma glucose were the leading risk factor for dialysis among women. As you can see, smoking has a much lower rank in women compared to male, while high body mass index has a higher rank among women compared to men. Also, alcohol use was among the top 10 leading risk factor for dialysis only among male, and unsafe sex was among the top 10 leading risk factor for dialysis only among women. Also, the ranking of risk factors substantially varied across different countries. Here you can see the leading risk factor for dialysis for both sexes, male and female combined, in 2016. The most common leading risk factor for dialysis across countries was high systolic blood pressure. In 81 countries, it was a leading risk factor for dialysis. In Asian countries, Central Asia, East Asia, South Asia, China, and also you can see that in the Latin America, Brazil, it was basically it was the leading risk factor for dialysis. The second most common risk factor for dialysis was high fasting plasma glucose. 37 countries, it was the leading risk factor. And mostly, as you can see, in Mexico, Iran, and small countries of the Oceania. Smoking was a leading risk factor for dialysis in 25 countries, Canada, countries of the Western Europe, and Southeast Asia. High body mass index was the leading risk factor in United States, Australia, and 21 other countries, specifically countries of the Middle East. And unsafe sex was the leading risk factor for mortality in 19 countries, so mostly in sub-Saharan Africa. In this round of GBD, we also evaluated the relationship between risk exposure and development. As you know, development in GBD was assessed by SDI, Socio-Demographic Index. Here it's basically represented in the x-axis, and y-axis shows the risk exposure, which is measured by SEV, or summary exposure variable, which is a risk-weighted basically exposure. And as this slide shows the relationship between development and risk exposure to top 3 leading metabolic risk factors. And among these 3, only BMI was positively correlated with development. The higher the level of development, the higher the exposure to high BMI. This slide shows the same relationship for top 3 environmental risks. All of them were inversely related with development, and the magnitude of the correlation was higher for household air pollution and also unsafe water sources. And this last slide shows the basically same relationship between behavioral risk and development. Top 3 behavioral risk. Smoking and alcohol use were positively correlated with the development, and short gestation for birth weight was inversely correlated with development. Like previous rounds of GBD, we also quantified the change in risk exposure. This slide shows the relationship between attributable DALI in 2006 at the global level. It's on the x-axis, and y-axis shows the annualized rate of change in exposure between 1990 and 2016. And different colors represent different types of the basically risk factor groups: behavioral, environmental, and metabolic. This graph can be basically divided in 4 different categories. Risks that are basically on the lower left quadrant, they have a low burden and decreasing trend. Those that are basically on the left upper quadrant, they have a low burden but increasing trends. Those that are basically on the right lower quadrant, they have a high burden but they have a decreasing trends. And the ones on the right upper quadrant, they have a basically high burden and increasing trends. And this is particularly important. These are the risk factors. Both we already have a high burden and their trends are increasing. And if you are interested in which risk factor falls in this category, as Steve also mentioned some of these risk factors in his presentation: high body mass index, high fasting plasma glucose, alcohol, and ambient air pollution is some of the important risk factors that falls in this category. This slide also shows the story of other clusters of risk. For example, if you are interested in risks that are related specifically to different types of malnutrition and want to see how they have how the nutrition transition affected this risk factor, this slide can answer that question. Here you can see the risk factors that are directly or indirectly related to nutrition. The risk factors that are related to undernutrition are decreasing. The risk factors that are related to overnutrition are increasing. And the trends for these factors that are related to diet quality have different trends. The exposure to high intake of sugar-sweetened beverages and red meats are increasing, while the exposure to trans fatty acid and low intake of fruits or low intake of vegetables are decreasing. And finally, in GBD, we evaluated the percent change in risk attributable DALYs and quantified the contribution of different drivers, including population growth, population aging, risk factor exposure, and all other factors, which here we call it risk-related DALY rate. As you can see in this figure, population growth has resulted in higher DALYs in 2016 compared to 2006 for all causes, and population aging has resulted in higher DALYs due to basically all causes, non-communicable disease and injuries, and lower DALYs due to communicable diseases. On the other hand, risk exposure and risk-related DALYs has resulted basically in lower DALY rate in 2016 compared to 2006. And overall, risk attributable DALY for all causes are decreasing. Risk attributable DALYs for communicable disease are decreasing, while risk attributable DALYs attributable to non-communicable disease and injuries are increasing. As I mentioned, in this round of GBD, we have tried to make several methodological improvements, but there are many other areas that can still be significantly improved. Perhaps one of the most important areas of improvement is the method of selection of risk outcome pairs. Currently, we are using WCRF criteria, but these criteria are subjective, and different groups of scientists might have different interpretation of the strength of evidence. To address this limitation, we are currently in the process of developing new evidence grading system for GBD. In this new approach, we are aiming to go back to all the studies that assessed each individual risk outcome pair and compute a causation score for each of these single studies based on a conclusion and the quality of studies. Then we plan to create the distribution of risk score for all the studies that assess each risk outcome pair. And then based on a median and interquartile range of this risk score, we are aiming to categorize the risk outcome pair to 5 different categories, where 5-star represent the strongest evidence for causality, and new studies might not basically change our interpretation of the strength of this causal relationship, while 1 or 2-star studies that we have very weak evidence, and more studies are needed in this area to establish causality. Other areas of improvement in the risk factor section of GBD includes improving exposure definition for different risk factors, updating the relative risk, both the age curve of the relative risk, dose response curve of the relative risk, and the magnitude of relative risk for different risk outcome pairs, and also updating how we define TMREL, or basically how we estimate the TMREL across different risk factors or optimal level estimation, and also updating our mediation matrix. Thank you very much for your attention to this presentation. I look forward to our panelists' comments, and I would be more than happy to answer any question that you might have about our work. Thank you.
Thank you so much, Dr. Afshin. What great progress we've seen in just a year even on risk factors. So I'm going to turn it over to our esteemed panel. Dr. Stein will be first to give some comments.
Thank you. And thank you very much indeed, Ashkan. This was a really excellent presentation. And thank you and congratulations, first and foremost, to GBD and to all the collaborators. I think it is worth emphasizing that this is really a celebration, despite the difficulties, despite all the hurdles and the holes we can pick into work. This is really an amazing, amazing piece of work. And from a professional point of view, my heartfelt congratulations. But also from a personal point of view, I have to declare a conflict of interest here. I worked for Chris and Alan for several years at WHO headquarters during the GBD 2000, and finding firsthand how difficult it is to do such work and how far it has come since. So this is really a wonderful moment. But I think it's not an exaggeration to say that, and this is certainly the view of WHO Europe, that the GBD effort is probably the most important health information effort worldwide. This is so important to our member states, and every day I'm actually asked, what are you doing in burden of disease? And this is why we at the WHO European office have started intensive work a few years ago with GBD. We're probably the people who at WHO are maxing out on the memorandum of understanding that we have with IHME. But as Stein was saying this morning, we actually have a European burden of disease network. We think this is so important that member states need to get together, need to fill data gaps, but also provide information in a harmonized way, in such a way that it can be used by international efforts, such as GBD, but also WHO. If everybody went off and did their own thing, we would really never be able to compare. And this makes also this piece of work so incredible, extraordinary. I will say a bit more about later why I think and what I think we need to do in order to really bring this to the people. But first, let me comment a little bit on the work on risk factors. For policymakers, as David was rightly saying, this is where the rubber hits the road, because this is really where the interventions are placed. You wouldn't find a single policymaker said, I want a policy to reduce cardiovascular disease. They will say, I want a policy to reduce alcohol consumption or to deal with smoking rates. So this is really where policymakers are truly interested. This is the most important part for them, because everything else will follow. If you can reduce those risk factors, you will see that there will be a lot that will be reduced in terms of burden of disease. So it's no wonder that this is really, in my view, one of the most exciting parts of the GBD, and there's no wonder that we see the results that we saw so far. But there are also a couple of things in the presentation and in the paper, in the Lancet, that I feel are really worth commenting on. Let me say two things. First and foremost, it is amazing that some of the information and some of the areas have increased so much. And when I look at nutrition, I think this is particularly interesting. But one thing that I feel is missing, and I know that Chris will roll his eyes about this, is to see unsafe food as a risk factor in there. We have at WHO done a decade of work on quantifying the burden of foodborne diseases from unsafe food. Now you can imagine how complicated that must have been. It is not a trivial task, and if you think that some of these risk factors you have seen here are complicated, think again. When you think about unsafe food, we, for example, at WHO, we looked at 31 hazards causing 32 different diseases, causing 420,000 deaths every year, and that was in the year 2010, and 33 million DALIs. So not insignificant, but complicated, because you're dealing with different types of hazard, not just different hazards, bacteria, viruses, parasites, and chemicals. All of this can be foodborne. And then you're dealing with the incredibly difficult issue of source attribution. When does actually contamination happen? It can happen at the farm level, in transport, in retail, at the consumer level. It is really a complicated farm to fork kind of scenario. And then you have to attribute the source. Was it the water that contaminated the salad, or was it the salad that was contaminated? And so is it waterborne or is it foodborne? I mean, I'm really opening up a completely new area here for GBD that I think is very relevant, that WHO thinks is very relevant, and that causes a lot of death and disability. But it has huge policy implications. There is legislation, there is trade to be considered, transport, sales. All of this is really, really key, and we had a big discussion this morning about the intersectorality of health policy. That is at the forefront of intersectorality. I was very pleased to see that low birth weight has made it into the GBD list in recent years. It was there before, but it had a different aspect. Now I see that some of the outcomes you consider go into communicable diseases, for example. They also go into perinatal diseases. But I think this is also an area where I would like to push this a lot further. And this is also based on something that Dr. Sadana from WHO said this morning, thinking about the life course approach. I would here remind people of the work by David Barker, who was looking at fetal programming and the effect of low birth weight on adult disease later in life. That includes all the non-communicable diseases that we were looking on this morning, and I think it would be worthwhile pushing that boat out in that direction also. Just imagine what would happen to the ranking. It was number 4 in women, number 3 in men, I think, as a risk factor, if it was included, looking also at the effects on adult disease. And this is, of course, a huge area, but it is relevant for policy. It is relevant for what ministers of health would do, and that takes on a different connotation. So I would say let us use the GBD abbreviation and say go and be really, really daring and do that. I think this would be something that we would all applaud you to do. Of course, data gaps are huge, even in the best countries of the world. We know from the UN Economic Commission for Europe that even in Western Europe, countries are only able to report on 50% of the SDG indicators that have been agreed. That's a bit sobering, and you do wonder what would happen in other regions, but that is something we absolutely need to push. And we had a big discussion over lunch. Should we actually then really go for estimates, even if we're not really certain about the origin of the sources and the meaning of those data? We at WHO would argue yes, because you would actually start a debate and just look at what happened after the World Health Report 2000 debate. There was a massive flurry of studies doing health systems performance assessment, and I think that was a very important outcome. So let us be daring, but let us also take this work to the people. When I was sitting down there, I was looking at the poster, and this poster shows a young woman with her child, and how can we make this relevant to a young mother in what I believe is this Rwanda, where this photo was taken? How can we make it relevant to the people? We always talk about the big policies and the strategies, and nobody's more guilty of that than WHO. I think we are the masters of policy strategy and keeping it at the high level. But how do you get it to the people? If I were Richard Horton now, and I'm not, and because you said this earlier, I say it too, I would shout at you, take GBD to the people. Take it to the people. But how and who? And who should do it anyway? But let me give you one example, and I will finish on that, and that is the country of Iceland. Admittedly, a small country that can go out to the people, less than 500,000 population, and can talk to people in municipalities, in community town halls, about the health information and statistics reports they generate every year. They actually do that. They go out and say, this is what your community shows. You have these health problems, you have these risk factors. What do you think? Does it make sense to you? And what do you think should happen? And they enter into a debate. And they do this face to face in a country that is fully digital. So I'm challenging all of us to say that should we not actually go further than that? But then who should do it? Should it be the academics? Should it be someone like WHO or UNICEF who actually have a mandate with member states and with ministries of health rather than the general public? But I think that's worth having that debate, and I think we must have it. I think we must take it to the people, and I think that would have a major impact on the results of GBD, and it would actually then be what it always proposed to be, and GBD is a service to the people. Thank you.
Thanks. Thank you, Claudia. That was a wonderful perspective all the way from really high-level policy all the way down to the individual. So that was really wonderful. Our next speaker is Dr. Brauer.
So thank you, and it's really a pleasure to be here to celebrate with all of you this really massive accomplishment of the GBD. So I'm going to speak about, from my perspective, as a risk factor expert, I come at this from somebody who works on environmental risk factors, and specifically I'll illustrate some points through the work that I've done as a contributor and a collaborator with household and outdoor air pollution. When I first got involved, I saw that GBD was something that was going to be important with respect to this risk factor. And what I didn't realize at the time was that it was going to force us to address and answer some key questions that we really should have known all along. And so with that in mind, I'd like to cover 287 points, but I'll, in the interest of time, I'll limit that to 4 key points. So how much does this risk factor matter? A very basic question that we actually didn't know the answer to for many risk factors. Where is it good? Where is it bad? Where are we most uncertain? Are things getting better or worse? And can we identify high priority questions And this is really key. So I think one of the benefits of GBD has really been to identify research questions that those of us who are doing primary research, and I spent my whole career prior to getting involved in GBD doing primary epidemiologic studies, and I would be happy to continue that, but without really any guidance in terms of actually what were the high priority questions that we weren't answering or weren't asking and addressing. And then I'll just close with some comments about looking forward. So how much does this risk factor matter? And I'll talk a little bit about household and outdoor air pollution. Arguably, the GBD has transformed our understanding of the importance of outdoor air pollution and household air pollution on health. It's really put this risk factor on the map, so to speak. And we can look at the example of China, where I think many people had appreciated China's strong role in terms of greenhouse gas emissions contributing to climate change. But it's really been the impact of outdoor air pollution, which has common sources. So the sources that contribute to climate change relevant emissions and outdoor air pollution are the same. But it's been the emphasis on outdoor air pollution and managing that problem as a health problem that's really started China's transition to being a cleaner energy country. So arguably, GBD has changed the trajectory of climate-relevant emissions in China through this impact on outdoor air pollution. We've seen a similar pattern with household air pollution. The profile has increased globally, and India specifically has really, for the first time, started to appreciate the importance of this as a risk factor for health and to address this problem on a national scale. And as one very recent example, just this week, Prime Minister Modi announced the acceleration of India's electrification, so that the estimates now will be that India will be fully electrified, so everybody will have access to electricity by 2018. Of course, access doesn't mean fully adoption of cleaner energy sources, but it's the first step along that path. And again, arguably GBD, by putting this risk factor of household air pollution high up on the health burden profile, has contributed to that. We've also seen a whole cottage industry building upon the GBD work to look at policy analyses, and in particular related to air pollution. So pretty much every week a paper crosses my desk to review, looking at some future scenario analysis, some policy analysis. What if we change this source in terms of air pollution? How is it going to affect health burden? All of those analyses are based on and have at their core the GBD exposure response relationship, the GBD burden information. So this is really driving policy analyses at the global level, the regional level, the national, increasingly at the local level. Secondly, would be precision, and specifically in relation to environmental risk factors, spatial precision. So we now have the ability through what is, in my mind, a second data revolution that is comparable to the omics revolution, which is geospatial data. So we can estimate for many environmental risk factors at very, very high spatial precision globally, the levels of exposure. And we've used that, for example, to understand how air pollution varies on a meter-by-meter basis in cities. And once we can fully utilize this information, we should be able to get down to the local level where really action on environmental risk factors is taken. So for the example of air pollution, we've seen China expand their monitoring network so that they now have the most densely monitored population in the world in terms of outdoor air pollution measurements. We also see that there's very, very little information on air pollution exposures in Africa in terms of ground measurements. So again, a key need to enhance the availability of that information. Talking about trends, for environmental risk factors, we've seen some really good news. As Ashkan showed, some real positive developments in terms of water, sanitation, household air pollution. And from a policy perspective, what is needed is really to now look at what's happening in these countries where we're seeing rapid changes and to actually accelerate those trends. So what is actually happening on the ground that's led to such rapid improvements? How can we accelerate? How can we learn from these messages and apply them elsewhere? And again, I would point out Africa as a bit of an outlier, where we're not seeing such rapid improvements as we have seen, for example, in Asia. Outdoor air pollution, the relationship with SDI is more complex. It's a weak relationship, if you see any relationship at all. And so there's a little bit more of a challenging story there. Because, of course, as countries develop economically, one of the aspects of that is that they increase their emissions, for example, as people have more access to electricity. Another feature of the trends that I've really begun to appreciate is the role of demographics. And for many of these environmental risk factors, that makes the situation very, very challenging. So as countries improve their health status, the population ages, lives longer, and in the case of air pollution, for example, it's the older segments of the population that bear much of the burden. So that creates a very challenging prospect for these countries. So for example, we did an analysis several years ago. Just for China to sort of keep its burden constant, they would have to dramatically reduce the levels of air pollution in that country, so the so-called treading water analysis. And I think we're going to see more of that in many countries as their health status improves. So speaking about high priority questions, so what do we have to do? What has GBD told us about outstanding questions? Certainly we don't have this perfect. There's room for improvement in the estimates, and we've seen through every iteration, as has been pointed out multiple times, that the methodology is improved. And it's very clear to me that the methods would not have improved without GBD. So it's really helped our overall work in terms of understanding risk to cause relationships. In the example of household air pollution, there's a big question in my mind on the relationship with cardiovascular disease. So that's why we're actually working together with Salim in the PURE study to do that study, where we can get the primary data to try and understand what is that relationship. We don't have high quality information on the shape of the exposure-response relationship for many of these risk factor caused pairs. And again, there's ongoing work in the air pollution field, both at the high end of exposure, but also at the low end of the exposure. And very importantly, we see many high prevalence diseases where we have very little risk factor attribution. And those really should be the priorities. So for any of you in the audience who are students and trying to figure out what to focus on, I would look at those high prevalence diseases where we don't know much about risk factors. So things like mental health, neurocognitive diseases, for example. And other risk factors that we may start to think about. We're seeing growing evidence, for example, of relationships between mental health and nature contact. It is something we can actually quantify exposure to on a global basis. And perhaps if we get strong enough evidence, that is something that could be included in future iterations of the GBD. So just to close, looking forward, one challenge that we have is as we've seen the massive health improvements and we've seen a relationship with SDI, some would argue that one component of SDI being related to economic development suggests that perhaps some of this health improvement has come at the extent of planetary health. So as we improve our health, the planet has borne some of that burden. Now that's not entirely borne out by the evidence that we have to date, but it's a reasonable question to answer. More importantly, we all know about the challenge we face in terms of climate change and overall harmony between ecologic health and human health. So thinking about actions to improve or to affect climate change, how might those actually be harnessed to benefit health would be a real challenge, and again, something I think GBD can contribute to. At the local level, which is where the action is happening in terms of drivers of planetary health and climate change, specifically thinking about some of those upstream factors, urban design, how are transportation networks designed to affect, again, perhaps benefit health in terms of physical inactivity, air pollution, et cetera, et cetera. And finally, as was mentioned in the discussion this morning, thinking about embedding risk factor prevention into health policy. While we've made strides, there's still a long way to go in terms of actually taking these risk factors and using them in terms of health policy, not risk factor policy as they have been traditionally. Thank you.
Thank you so much, Michael. That was great. I would like to thank you for not going through 287 points. That's really important. But also for your holistic approach. I think a call to action to not only improve risk factors, but also put that in the context of planetary health and climate change, I think is really key. So thanks. So our next speaker is Ms. Reitsma.
Thank you, and allow me to start by saying that it is an honor to be speaking with you today and to be sharing this stage with some incredible scientists. I've had the opportunity over the past 3 years to work on estimating risk factors as a GBD researcher and as a post-bachelor fellow. Specifically, I work on the tobacco use and high body mass index risk factors, which together accounted for more than 10 million deaths globally in 2016 alone. And as Dr. Afshin mentioned, they're leading risk factors for both men and women. Now this week, we're celebrating the 20th anniversary of the GBD, which means it's a time for us to reflect on our accomplishments, but it's also an opportunity for us to look forward. In that spirit, I'd like us all to think about this really simple question. Where do we go from here? We asked ourselves the same question a year ago, before we started working on GBD 2016. For tobacco, the answer was adding smokeless tobacco as a new risk factor. Previously, we had been missing the 300 million people that currently use smokeless tobacco products, and we hadn't been capturing the leading risk factor for oral cancer in South Asia. For high BMI, the answer was adding childhood obesity, which has allowed us for the first time to estimate the effects of excess body weight across the entire life course in the GBD. We also completed a systematic assessment of the health outcomes that are caused by high BMI. The result of this assessment was that we added 8 new health outcomes. As Dr. Brauer mentioned, 4 of these were for outcomes that previously had been linked to no modifiable risk factors. What this does is it gives us a place to start designing interventions for primary prevention. Now, the public health community has made significant progress in combating the tobacco epidemic. But the results of the GBD show that progress has been variable. We're seeing a success story unfold in Brazil, where smoking prevalence has decreased by more than 50% over the past 3 decades. On the other hand, in Indonesia, 1 in every 2 men smoke, and smoking prevalence is significantly increasing among women. The evidence, to me, makes it clear where we should be going from here, and that is that we can and we should be using the results of the GBD to further our understanding of what policies work, where they work, and why they work. And then we should be using the GBD as a roadmap in order to identify the locations and the populations that must be targeted with these proven interventions and policies in order to eliminate the tobacco epidemic. Now, the obesity epidemic is particularly challenging. 2 billion people are overweight or obese globally. Let that just sink in for a second. 2 billion men, women, and children are overweight or obese. And this is not just a developed country's problem. Overweight prevalence is significantly increasing in 90% of countries around the world. We ought to think of the obesity epidemic as being where tobacco was 50 years ago. And right now, we're in exploratory phase. And where we should be going from here, it's uncertain. But I believe that the data can guide us, And to that end, we've compiled the largest database on obesity, and now we're going to start using that database to answer new questions. Namely, what are the drivers of the obesity epidemic? And then, what are some solutions? In summary, GBD 2016 risk factors analysis was a monumental achievement. But I hope that I've shown you that there is still so much more that we can be doing when we're always asking ourselves, where do we go from here? And before I wrap up, I do want to take this opportunity to thank the GBD collaborators in this room and watching on the live stream, because this is your work, and it would not have been possible without you. And I'm really looking forward to continuing this discussion and the collaboration so that together we can make the GBD as good as it can possibly be in order to improve the lives of people around the world. Thank you.
Thank you, Marissa. That was great. Certainly the variable progress around the world is really important to note, and also using GBD as a roadmap going forward, I think is really key. You know, the standardized approach to gathering and putting together these estimates is really the only way that we see moving forward, so thanks for that. Okay, so our final discussant is Dr. Salim Yusuf.
Well, thank you. First, congratulations to all the GBD collaborators. Congratulations to Chris, Alan, and the IHME team. The GBD certainly has made a huge difference. It's not a little difference, but a huge difference to the way we view global health and public health. It's taken us from description to the potential of modification. And on the first, it's the most reliable. On the last, it's the least reliable. And I will go through that. And if we think of it as three phases describing the burden of deaths, it's probably the most reliable of anything around in the world. That doesn't mean it's perfect. Trying to collect primary data from low and middle income countries, no matter how hard we try, 20% to 30% of deaths are just unclassifiable. So a lot of it depends on the assumptions. But still, this is the best data. You then go to disease burden, heart attack, stroke, mental health, backache. This starts to become quite difficult to quantify. Even the United States does not have reliable information on the burden of non-fatal events like a heart attack or stroke. These are estimates, but they're still okay. Risk factors, no country in the world has reliable data that is nationally representative, let alone the developing countries. Then risk factors to outcomes is the least reliable. And if for the first one, if I gave it a score of 5 out of 5, the last one I'd say is closer to 2. We really have to accept the limitations of what we have and not let our aspirational goals get ahead of the quality of the data or the reliability of the information. I know Chris is very aware of it. He and I have had a few discussions about it. Then certain conceptual issues. First, the concept of the counterfactual, it has to be rethought. It may be completely appropriate for external exposures like tobacco, like things that are not in the natural food chain for diet like trans fats. For air pollution, the real number is 0. But that is not true for the majority of risk factors. We have to replace this minimal exposure level to an optimal exposure level. Too low is bad, too high is bad. There is an optimal range. It's what we call in golf a sweet spot. Undernutrition is bad, too low a BMI. We've been battling this for decades in the world to overcome undernutrition. Suddenly, undernutrition is no longer the main issue when people do BMI versus metabolic risk factors. It doesn't matter. What matters are hard events. Same thing with blood pressure. Too low a blood pressure is bad for you. Too low hemoglobin is bad for you. Too high hemoglobin is bad for you. And the same thing can be said for practically every risk factor. So I would urge the GBD leadership to rethink that concept and go for an optimal range as opposed to a minimal exposure level. That will change your estimates substantially for a number of things. Then the second concept is modifiability. Even good prospective epidemiological data is an association. There are lots of confounding. And we know that hazard ratios that in the old days, Jeffrey Rose said under 2, but let us say with modern techniques, we use 1.5 or so, that you can't be sure is causal. Yet the majority of modeling is based on risk factor estimates that is less than 1.5. And then if you take the lower confidence limits of it, it's close, just above 1.1, 1.2. So we have to be humble in attributing causality to that. The third is nonlinearity. And many risk factors are not linear. Modeling that is much more complicated. The fourth thing is variability. I like to believe that risk factors have a universal impact. But take BMI as an example. There is very good data that BMI over 25 is bad for you if you're a white European or North American. But there's equally good data that a BMI under 25 is bad for you everywhere. So you can't say your counterfactual is any value below 25. There's also emerging and strong data that in South Asia, a BMI that is associated with the lowest mortality rates is around 30 or 32, not 25 or 27. These are outstanding data that Richard Peters collected on 500,000 people from Chennai with Gajalakshmi. So I believe the estimates of obesity, not as a BMI number, but as a health hazard, is probably off by a factor of 2 or 3. And I know my young colleague here has worked on that. But it needs to be rethought. The estimates on tobacco are pretty good, what it does in terms of deaths. But even there it varies by the type of tobacco, the age of starting, the reasons for stopping and the age of stopping, and the number of cigarette units smoked a day. In developing countries, the number of people start at a later age, they stop because they fall ill, and they smoke fewer cigarettes per day. So the estimates have to be different. But take hypertension, which figured very big in these numbers. I think it's horribly wrong. It's horribly wrong. It's based on just the epidemiological association of taking about 110 or 115 as a counterfactual. There are randomized trials, about 60 of them, on a total of nearly 400,000 people that shows no good evidence that lowering blood pressure, if you start off with a blood pressure around 135 or 140 systolic, reduces events. This is not small data. This is a huge amount of data. If you redo the modeling on hypertension, it likely, using the randomized data, then likely the impact may be half or a third of what is estimated in GBD. These are not trivial differences, these are big differences. Equally, something else like lipids are underestimated by GBD. The association between LDL and outcomes is continuous, and it's stepwise, and randomized trials have shown you there is no threshold at which if you lower LDL further, it will still keep on lowering events. So I think lipids are underestimated, and I agree it's hard to get good data on LDL from around the world. It's easier to get blood pressure. But that doesn't make blood pressure more important than LDL. Salt is a complicated area. There is a ton of data on about 500,000 people on about 20 studies that shows that sodium is associated with blood pressure, but the association is nonlinear. If you've got a lower blood pressure, the effect is modest. If you've got a high blood pressure, it's fourfold. There is equally good data that the hazards associated with high sodium is only at levels over 5 grams per day. And there's equally good data, not equally, there's some data that under 3 may be hazardous, even if you dismiss the lower end of the U-shaped you could at least say there is no benefit by further modeling. I believe the SALT data is off by a factor of 4 to 10. These are big differences. They aren't small differences. If you take, and this goes back to the classic teaching in nutrition, that there is the sweet spot, adequacy, excess, inadequacy. Sodium is key to bodily functions. It's key to the action potential. If you are a physician or a biologist, you know it's essential. How on earth can you argue that lowering sodium to such a low level, I can't see whether that's 5 minutes or 2 minutes, 1 minute, okay, that's even brilliant. Okay, so let me say that the dietary data on which the GBD is based has to be rethought. I want to leave you with a few thoughts for the future. The first thing is GBD needs to be a little more modest in its claims. You should put a health and safety warning, like these are based on modeling in 75% of the countries and only in real data in 20% of the countries. It should be big and bold. Second, we should not be completely beholden to experts, because some of the so-called experts are advocates, as Alan Lopez said. So you've got to differentiate between people who look at the data objectively. And the third thing is, do incorporate data from randomized trials. I see that there is an attempt to do it, but I haven't seen it actually incorporated in the papers unless it's there in the latest version. So overall, GBD has done us a tremendous service. Can it be improved? Definitely. Does it, many aspects need to be thought? Yes. And I hope my comments, while it may seem like raining on your party, I hope it isn't. I'm an admirer of GBD, and I'd like you to live long, prosper, and do well. Thank you.
Salim, thank you so much for those comments. I think you found the perfect balance between salty and sweet there. So thanks. No, really, I think underscoring the need for better data out there is really important, and I think we all recognize that, and I think the GBD can be used to call out those data gaps really importantly. Okay, so now that we've heard from all of the panelists here, we'd like to hear from you. So I know there are microphones out in the audience, so.
We reflect to respond to some of the potential issues, or
I think we're going to get some questions from the audience, and then.
Hello? Is it on? Hi. My name is Janice Tufty. I live here in Seattle, and I'm a patient or a person involved in research. I've been with Group Health Research Institute and up to the National Academy of Medicine. I work in measurements, and I do not have a degree. I just want to mention, I've heard two of you today really mention the importance of having, like if this young mother was here today, it is very important. And I became involved through the Patient-Centered Outcome Research Institute. I'm not necessarily advocating it, but it is has brought research available with a patient voice into all levels of research. So next time I come, I hope that you might be able to develop something called GBDPRI, so GBD People Research Institute, and include them in all the different countries, because they do bring the preferences, the values, and the relevance to all the projects. Thank you.
Howard Hu again, University of Toronto. The discussion's been great, but I want to follow up on Yusuf's comment about primary research. It's not only so important to continue doing the research on what the true impact is of the risk factors, but the risk factors themselves deserve a bit of a disclaimer. Hypertension, as an example, is cited as a risk factor, but in fact, we have no idea what really causes hypertension. What we do know from the twin studies and from the human genome-based research so far is that we can only explain less than 10% of hypertension, and the twin studies tell us that less than 40% of essential hypertension is likely due to genetics. whereas in fact there is growing evidence of the impact of prenatal risk factors as cited by Claudia in respect to the Barker hypothesis. So I think there's the idea that we have identified the risk factors and now we just have to figure out how to judge their importance has to be also founded on this idea that we still need desperately good primary research on the things that are driving the actual diseases. And hypertension really is an intermediate risk factor. Similarly, for cancer, the Swedish twin studies show us that less than 50% is heritable, and that we still have so much to do to really identify the upstream risk factors for most cancers.
Would you like a response to that comment?
Sure.
I agree with you. It'll be useful to identify upstream risk factors, but it's been notoriously difficult for most things. If you look at the countries that have had the biggest changes in deaths, premature deaths from, say, cardiovascular disease, it could be other diseases too, like the US, Canada, much of Western Europe, Australia, you will see that apart from tobacco rates going down, almost all the rest of the impact has been through better treatments. I think during this period, BMI has gone up, cholesterol levels haven't gone down a whole lot, maybe a little. Blood pressure levels pre-treatment haven't gone down. People claim diets have gotten worse. It depends on your evidence for what it is. So I think we should we should continue to do research as to what causes the risk factors. In fact, a lot of our work is in that. But we shouldn't let that get into the way of what is possible. And what is possible right now is to treat the risk factors and to treat people who get the disease effectively. And given that countries like the UK in the last 40 years have halved their CVD rates and then halved it again, 75% reduction, and most of it, apart from the smoking, is due to better treatments. We shouldn't lose sight of the fact there's a huge gap between ideal treatments for risk factors and treatments with the disease compared to what is being done in most of the world, low and middle income countries. So risk factor research is good, but you need to look at health systems as well.
Actually, I agree with what you're saying, and some of the work that we're doing on the GBD through the decomposition analysis is allowing us to start looking into not only what are the effects in reducing risk exposure, but also what are the other factors, such as improved treatment, that are also helping to ameliorate some of the attributable burden. For example, for high BMI, we have increasing risk exposure nearly everywhere, but a lot of the cardiovascular disease burden has been prevented by improved treatment of those diseases. And then if you look at something like cancers, you can see that the treatment just hasn't caught up to where CVD is, and there's a lot of room for progress in that area.
Hi, I'm Ami Banerjee. I'm a cardiologist from the UK at University College London. So I understand with the causes of death that one death has one cause, but risk factors come in multiples. And this is an area that we need to think really creatively about how we model this, because nobody can answer this question better than the GBD, but at the moment we're approaching it one risk factor by one risk factor. So if I'm wearing a policy hat, then we're in danger of creating vertical programs for each risk factor, and that's entirely the wrong approach. So how can we move forward on that agenda?
You should answer that, Marissa.
Sure. So it's a very interesting and perhaps important question. So currently what we are doing, basically we are in GBD doing a single risk attribution. As you mentioned, basically we are estimating the proportion of disease attributable to each risk factor. We are also trying to basically estimate the a cumulative effect of different risk factors, or the joint contribution of different risk factors to disease mortality. This needs basically a more complicated and complex analysis to take into account the joint distribution of the different risk factors and how they interact with each other and how they basically affect the disease incidence or mortality. One of the work that we are currently in GBD, we are in the process of creating the database of different cohort studies that assess risk factor at baseline and during the basically follow-up time, and assess the relationship with the incidence and mortality of disease. And try to basically redo some of the analyses and see that how the joint distribution or different risk factors basically affect each other and affect the basically burden of different diseases. Distal risk factor and basically proximal risk factor. And we're also trying to take it to the next level and use more advanced statistical analysis, new methods including machine learning, neural network, and more complicated data analysis method, and see that whether the findings of these new approaches basically improve our understanding of the interaction of different risk factors or the cluster of risk factors that they and how they basically impact incidence or mortality from different diseases.
Can I just add to that, David? I think that comment is important, and the comment from Amitabh is very relevant. It's true that risk factors cluster, obesity clusters with high elevated glucose, with dyslipidemia, but it's usually low HDL, nobody's talking about that, and blood pressure. But actually, other risk factors are much more risk exposures, I won't call it risk, are much more complex. An example of that is diet. Diet is not only what you eat, it's what you don't eat as well. The second part of it is how you eat it, how you cook it matters. How it's grown matters, because they may have insecticides, pesticides in it. Who you eat it with probably matters, whether you eat it slowly or whether you eat it in a group. So that when you don't eat one particular thing, you eat more of something else. Diet is the most complicated exposures, one of the most complicated exposures I know of. By comparison, tobacco is a piece of cake, you know, and even indoor pollution or outdoor pollution is straightforward. You're not replacing indoor pollution with another toxin or this thing. So I think the diet part of GBD needs considerable care and thought, because you could get it completely wrong.
So if I may say something about the diet, I totally agree. Diet is one of the most important and perhaps challenging aspects of GBD. And when it comes to diet, it's really important to see that where we have evidence and where we think we have evidence. For example, when it comes to the basically method of cooking, it's interesting, it can be important, but do we have evidence for that? In terms of how cooking method basically, in a long term, affect different diseases. Also, when it comes to effect of other aspects of diet, our evidence is very limited. We all know that basically evidence comes from mostly cohort studies. Cohort studies have food frequency questionnaire, and the food frequency questionnaire has their own limitations. And it's important basically to acknowledge the limitations, and this is what we are trying to basically do at GBD. We know what are the limitations, and we try to basically make the best decision based on the limitations that we have. I just want to quote Milton Weinstein from Harvard Decision Center, and he has a very interesting point. That his quote is that decisions have to be made. We cannot wait for perfect evidence. We can basically make the best use of our current evidence. And in diet, this is what we are trying to do. We are trying to make the best out of the existing evidence and try basically, is it not changing from 5 years from now? It might change, because this is the this is the nature of the science. We don't treat people, we don't make the same recommendation that people used to make for treating high blood pressure 50 years ago. Science is improving, the science of nutrition is also improving, and every year we are systematically evaluating the evidence to see that what are the new evidence, and incorporate that. And I am very interested to see the analysis that you have done and how you reach to the conclusion that some of these estimates are 5 times or 10 times off. I would appreciate if you could share this with us, and we will definitely consider it, and it's help us improve our estimate. We will definitely do that.
We'd be happy to sit down and do that.
Thank you.
Okay, a date. Okay, are there other questions or comments?
Hi, I'm Jessica Taff. I'm a scientist working out of National Institutes of Allergy and Infectious Diseases. I want to comment or ask a question and to get some feedback on moving ahead with the global burden of disease and risk factors, and wondering what opportunities you think there are for using biomedical data and biomarkers, particularly things like genomics, metabolomics, proteomics, in helping to inform the data that we currently have and the risk factors that we're already using. I recognize that this is definitely a set of data that's not easily accessible in a lot of places, but I think moving ahead, it would be a fantastic way to really push the boundaries of what the GBD study could do.
That's a great question, and we are aiming to use the sensor data and basically data that are collected more objectively. One of the main challenges that we currently have is the representative of this data. Most of these data are among the people who are highly motivated people who are basically participating in a specific study or using these devices. And how representative of these data are basically very questionable. For example, we are very interested to use data for accelerometer or basically data that are collected through Fitbit and other things. And some of these databases are available, and we try to use them. Unfortunately, the current databases are not very representative, and there is a large amount of basically selection bias, which prevents us from using these data systematically in GBD. But as long as we have this data set that is representative of population, we are more than happy to include that in the GBD.
I think the issue on using any biomarker is far more complicated than representativeness. It's whether that particular biomarker you can attribute causality or the entire difference. Let me give you 2 examples that will make us pause and think. Many studies have shown that the higher the glucose level in the blood, a simple biomarker, more heart disease, more strokes. But no good evidence exists from randomized trials that lowering glucose reduces ischemic heart disease or stroke. I don't know why. Is it because we have characterized diabetes based on glucose, and glucose may be an epiphenomenon, and that the underlying disease may be problems in fat deposition? And therefore, by going with a biomarker and changing it, we may be going after the wrong thing. Second one, something that we believe, and I believe is true for most things, is LDL. Yet, different approaches to the same LDL may be associated with different particle size of the LDL, and large particle LDL, while they give you high values, are far less atherogenic than small dense LDL. We're doing a lot of work on biomarkers. Probably a third of our work is related to it. But the more work I do, the more I'm reluctant to attribute causality through a specific pathway.
Okay. On that note, please join me in thanking our speaker and our esteemed panel.